Welcome to Clinical Minute. Lillian Johnson is an obstetrician-gynecologist in an outpatient clinic, supervising medical student Sarah Scott. Sarah has just completed a patient interview. Sarah presents the case to Dr. Johnson. Jennifer is an 18-year-old Nulliparous college student who presents today for a new prescription for oral contraceptive pills. She has used combined oral contraceptives in the past, but the prescription ran out 6 months ago and has used condoms alone since then. She has been monogamous with her current sexual partner of 2 months. There is no significant medical history or family history. She has a history of moderately heavy periods. She denies tobacco use. Dr. Johnson replies, "Before we go in and see Jennifer together, tell me what you would do next." Sarah responds, "I think she's a good candidate for combined oral contraceptives. She has used them in the past and wants to continue. She has no medical contraindications to hormonal contraception and is a non-smoker. However, she should also use condoms to prevent sexually transmitted infections." Dr. Johnson nods, and they proceed into the exam room. Jennifer's blood pressure is 118/72. Her physical exam is normal. There is no need for a pelvic exam unless Jennifer decides on intrauterine contraception. Dr. Johnson counsels Jennifer about her contraceptive options. She recently learned of the One Key Question initiative of the Oregon Foundation for Reproductive Health, which encourages primary care providers to routinely ask women of reproductive age a simple question. She asks, "Would you like to become pregnant in the next year?" Jennifer replies with an emphatic, "Definitely not." Dr. Johnson then says, "It can be difficult to remember to take a pill every day. How often would you estimate that you would forget in a month?" Jennifer admits to missing about 3 pills per pack. She says, "I'd really like contraception that I don't have to think about every day." She states that she uses condoms with new partners, but not after we've been together a month or so. Dr. Johnson shows Jennifer a chart that compares the effectiveness of various contraceptive methods at preventing pregnancy. She explains that intrauterine contraception and implants are considered long-acting reversible contraception, or LARC. These are reversible methods that are top tier in preventing pregnancy, meaning that less than 1 pregnancy per 100 women occurs in a year when using these methods. They also are forgettable. Jennifer says she would like to try intrauterine contraception and asks, "Why haven't I ever heard of intrauterine contraception? Is it new?" Dr. Johnson replies, "Intrauterine contraception has been used for many years. In the past, we thought it could only be used in women who already had a child. Now we know intrauterine contraception is effective and safe for adolescents and for women who have not had a child yet, although we need to be sure to counsel these women that intrauterine contraception will not protect them from sexually transmitted infections." She offers the option of insertion that day, but Jennifer prefers to return in 2 weeks when her midterm exams are completed. She chooses to use the contraceptive patch as interim contraception. Dr. Johnson conducts a bimanual exam, which shows a nulligravid retroverted uterus with no abnormalities. The cervix and vagina are free of mucus and pus. Dr. Johnson sends a cervical swab for gonorrhea and chlamydia. She provides a prescription for the patch, and Jennifer makes a follow-up appointment for insertion. If the STI tests are positive, Jennifer can be treated without delaying insertion. Dr. Johnson takes a few minutes to discuss the case with Sarah. She highlights the importance of effective contraception among adolescents by presenting a few statistics. She tells Sarah, 49% of pregnancies in the U.S. are unintended. About 3 in 10 adolescents become pregnant in the U.S., a rate that is much higher than that seen in other developed countries. While the failure rates for ideal and typical use are very similar for LARC, the rates are quite different for combined oral contraceptives. The perfect use failure rate for combined oral contraceptives is less than 1 per 100 women per year, but the typical use failure rate is about 9 per 100 women per year. Also, as many as 60% of adolescents discontinue use of combined oral contraceptives within the first year. But the Contraceptive Choice Project, conducted by Washington University School of Medicine in St. Louis, found that more than 84% of adolescents who chose intrauterine contraception were continuing with the method 1 year later, compared with 55% of those who chose combined oral contraceptives. In addition, satisfaction rates after 1 year of use were higher among intrauterine contraception users than combined oral contraceptive users in this study. In addition, LARC has few contraindications, which you should definitely be aware of. The point is that adolescents are appropriate candidates for LARC, including intrauterine contraception. As a provider, you should know the full range of contraceptive options, but emphasize the most effective first and foremost. Dr. Johnson continues, there are 3 forms of intrauterine contraception currently available in the U.S., 2 levonorgestrel intrauterine systems, Mirena and Skyla, and Paragard, a copper T IUD. All of these methods are appropriate for adolescents and nulliparous women. Sarah asks, how do you decide which intrauterine contraception is best for a particular patient? Dr. Johnson replies, take a look at this chart. The copper T IUD, or Paragard, is ideal for a woman who doesn't want hormonal contraception. In addition, it can be used as emergency contraception. The levonorgestrel 52 intrauterine system, or Mirena, is a good choice for women who have heavy menstrual flow. It has an indication for this use. And the levonorgestrel 13.5 intrauterine system, or Skyla, has a smaller frame and is a good option for women who desire a smaller dose of levonorgestrel. Dr. Johnson continues, just as it's important to evaluate a patient carefully when helping them choose a contraceptive method, it's also important to provide certain counseling messages. Any ideas about what some of these key messages about intrauterine contraception might be? Sarah looks puzzled, then responds, women should know that intrauterine contraception doesn't cause infection. I'll bet a lot of women don't know that. Dr. Johnson replies, right, that's important. I also make sure to tell women that intrauterine contraception is extremely effective at preventing pregnancy, that intrauterine contraception does not prevent STIs, condoms should be used consistently with new partners, and that bleeding patterns often change after intrauterine contraception insertion. With the levonorgestrel intrauterine systems, bleeding frequently decreases over time. With the copper T IUD, bleeding often increases initially, then normalizes after several periods. I also tell women to contact their care provider for increasing pain or bleeding, as these could be a sign of possible expulsion, pregnancy, or infection. Finally, I ask if she has any questions. Sarah asks, I thought intrauterine contraception increased the risk of pelvic inflammatory disease and infertility. Dr. Johnson replies, actually, a study of about 20,000 intrauterine contraception users found that the risk of infection after intrauterine contraception insertion was low, even during the 21 days right after insertion. In fact, it is less than 1%. After 21 days, the risk of infection was 1 per 1,000, which is no greater than that for the general population using no contraception. For this reason, prophylactic antibiotics are not needed for intrauterine contraception insertion. Sarah follows up with another question, but what about STIs? I know women under 25 need screening for STIs like chlamydia and gonorrhea. Don't you need to rule out infection before inserting intrauterine contraception? Dr. Johnson replies, you're right that STI testing should be obtained before insertion if the patient is at risk for infection, meaning she is less than 25 years old or she has multiple sexual partners. However, we don't need to delay insertion while waiting for STI test results. If a test returns positive, we can treat the infection with the intrauterine contraception in place. Sarah asks, I thought intrauterine contraception could only be inserted during the menstrual cycle. Can it really be inserted at any time? Dr. Johnson tells her, yes, it can be inserted at any time during the menstrual cycle as long as the provider is reasonably certain the woman is not pregnant. If possible, I like to place intrauterine contraception on the day of the visit. If not, then interim contraception, such as oral contraceptives, the contraceptive patch, or the vaginal ring, may be needed. Dr. Johnson asks Sarah, "Any other questions before we see the next patient?" Sarah asks, "Do you find it difficult to insert intrauterine contraception in a busy clinic like this?" Dr. Johnson smiles. "It can get hectic sometimes, and we had to work out a system to have intrauterine contraception available for same-day insertion. But once we worked out the kinks and made sure everyone received appropriate training, it's been easy to offer intrauterine contraception, even in a busy clinic. And as you saw with Jennifer, many patients opt for intrauterine contraception when given the choice. Ready for your next patient?" "Sure am. Let's go," replies Sarah, and they move on to greet the next patient.